Hi, good afternoon, everyone. Thanks for joining us for Echo Teaching today. We are going to go through Tamponade, and I've got 3 cases to discuss. The first one's just a kind of routine Tamponade, and we'll just make sure we go through all the findings that you're expected to pick up. And then the next 2 are cases, again, of obvious, pericardial effusion to tamponade physiology, but they've got a few variations on the theme, which I think are quite interesting to be aware of for potential, complications, the nuances in, I guess it's more of the advanced setting. These are ones that have come through the unit where it's important to understand the basics, but then having an idea of the advanced side of things as well. So why don't we start off with the simple kind of things? And Hatem, you've got the exam coming up in 14 weeks. So these would be the kind of, for the exam, I guess we do have more advanced cases in there, of course, trying to push those who might be getting the prize. But the bottom line is that most of them are going to be fairly, just like an ICU exam. You'd have the robust, basics that you've got to do well. And then there are the advanced things. If you're going to go and get the prize, then great if you can get those. I think this first case would be more of an example of the one that we put into the exam. So we'll start with this. And this is a 54-year-old patient who's come into the ICU a year or 2 ago. He's come in presenting with a 3-day history of severe pleuritic chest pain. He's had a recent VQ scan, which was unremarkable, and a CT angio, which was unremarkable, only minor disease. But he ended up on the CT scan showing that he had a small pericardial effusion. He was treated with prednisolone, but then he starts to get worse. And that's when he comes into the ED, and he's got increasing breathlessness and hypotension. And an urgent echo is done to have a look for this. And the echo says, previous pericardial effusion, shortness of breath with relatively minor findings on these CTs. Have a look. So why don't we start with a standard view? Go for it.
Okay, so this is a person along axis view with the rhythm showing in sinus rhythm with ST segment elevation. So probably I'll try to correlate this with ECG. And it's showing normal biventricular function with normal appearing valves. Size of the all chambers looks okay. The heart is surrounded by an echo-free space of around 1.5 centimeter. Probably on the right ventricular side or the RVOT, there is potential for some compression or collapse that's happening. Probably I'll try to correlate it. I will slow down to correlate it. This is a far image, including the lung. Probably there could be an underlying pleural effusion as well.
Nice.
So,
Sorry, I forgot to tell you the important past medical history, excuse me, which is that he's known to have Child-Pugh C liver cirrhosis, previous encephalopathy, and jaundice, but that's not a major issue at the moment. So he has been in ICU previously for that. I'm sorry, I forgot to tell you that.
so probably in the clinical context, in correlation, probably this could be representing either pericarditis, acute pericarditis, versus generalized edema with anasarca.
Nice. Okay. I think you talked about there being small pericardial effusions. Tell me about your differential between small, moderate, and severe pericardial effusions.
So I think I'll recall it back. It will be moderate. So my sizing will be less than 0.3 is minimal. Between 0.3 and 1 would be small. 1 to 2 will be moderate, and more than 2 would be large.
And when are you measuring it? Because if
And
you go here, I mean, you'll see we've put a cursor here through M mode through the aorta, if you like, and we can see.
so I measured
as we go through,
during
we've got
diastole.
pericardial effusion here, so I can measure it here and it's 0.3. I can measure it here and it's 1.2 or something. So where do I measure it?
So I measured at end systole.
Very good. Or you can measure it also. They talk about it's the largest apparent space as well.
Yep.
So you've got to pick the largest spot. So I think it could be down here as well. Yeah, so nice. So you can measure it down there.
Does that vary with, I mean, that would vary with where you're measuring. So if you're measuring it near an atria doing a view, then you're going to measure it not at end. Systole, you want to measure when it's the biggest, right?
Measure it where it's the biggest in the biggest spot.
Yeah.
So you're saying if you're measuring the atria, it should be different.
Because you'd measure it and
Diastole then.
Yeah.
I think that's correct. Yeah, you're measuring its greatest spot, and
Yeah.
if it's in the ventricle, you measure the greatest spot, and that would be the end
Measuring
systole or
atrium.
the early diastole, and then the other way around for the atrium. Absolutely right. So yeah, it's its greatest spot, and as you said, I have physiological being though if it disappears during the relaxation phase, and that'd obviously be different for the atria or the ventricle. So if it disappears completely during the relaxation phase, and then less than 1, 1 to 2, greater than 2. Very good. So what's next? Okay, so if you're worried about the pericardial effusion, what else do you want to see?
So I'd like to see an mitral and tricuspid inflow on apical fourth chamber. I'd like to see a short axis over the mid-papillary muscle or mitral valve level, so I can identify the right ventricle, whether the interventricular septum, whether there's an interventricular. Sorry, no, I recall it back. Sorry, wrong. I'd review it in different in other views and images.
Nice.
But yeah, definitely I would review it in the apical fourth to identify the inflows and the continuous wave Dopplers across it with variability.
Beautiful. So if we're talking about 2D, just can't try and keep it structured. So if it's 2D, you're always going to want multiple views looking for the maximum diameter. What else are we looking for on 2D? So if we're running about tamponade, you said you've got a moderate sized pericardial effusion. Can a moderate sized pericardial effusion cause tamponade?
Potentially. So it depends on the rate of accumulation.
Fantastic. So acute pericardial tamponade, you need a smaller amount of fluid than chronic. Okay. At the moment so far, you've told me about these 2D findings, but again, it's all about matching it with the clinical issues. I've told you he's short of breath so far. One of the things that'd be really great for the examiner not to have to push you on.
Yep.
So
Definitely
links up with clinical findings.
Yeah. So it needs to be correlated with the hemodynamics of the patient.
Nice. Because I just told you he's short of breath at the moment, didn't I? I just said that he was short of breath and he came into ED and he was getting increasingly breathless and there was potential for hypotension. I can't remember exactly what I told you, but so just try and always link that back in. So I think the kind of, I guess what would be nice is to say, if you're seeing this echo-free space and we've seen that we've maybe got this indentation in early diastole of the right ventricle free wall, is to start linking it in to saying that potentially, therefore, there are signs of echocardiographic signs of tamponade. And then the buzzword I want to hear. Tell me what I want to hear about if you're going to start to say the T word.
So diastolic collapse, more than third of the diastole.
Sure. These are other things, but the first thing, before you start talking about anything else, you've got to make the examiner feel happy, because how do you diagnose tamponade?
So tamponade is a clinical diagnosis.
All a clinical diagnosis, fantastic. So before you say anything else, if there's a pericardial effusion, just the examiner, that's got to be a big old tick on the examiner's marking sheet. And of course you know it, but it's like saying that you've got to have a family discussion meeting. If they say, what are you going to say to the family in a Viva, right? You've always got to say, I'm very worried about this patient. I want to have a family discussion. So just make sure tamponade, it's a physiological diagnosis. You said this guy's short of breath. And is there signs of hypotension? Is there signs of shock? Mention those JVP if you want to, but I think more importantly, it's short of breath that's worse on lying down flat. And then we can start looking for the echo features to support that diagnosis. Okay, and so you talked about the size, you talk about the free wall collapsing, and that's the RV. Which free walls do you worry about, and what order of?
So right atrium first, as right atrium will be more sensitive, and it will be during systole, and then right ventricle will be late, and you need at least third of diastole of collapse, and it will be the diastolic collapse of the right ventricle.
Fantastic, particularly to early diastolic collapse. And any other chambers? You said right atrium, right ventricle.
And the IVC, so IVC would be distended and not collapsing.
Fantastic. Left atrium can also go as well, but it's not as common. I think it's worth mentioning. Sweet. Okay, tell me what you're seeing in this view. What's this?
So this an M mode across the mitral valve um, in the parasternal view, and this is showing. So probably the most important finding here is the right ventricular wall or the right ventricular outflow tract wall, um, and we can quantify the amount of effusion through it. So the effusion can be quantified both on the over the right ventricle and as well over the posterior wall of the left ventricle.
Nice. What anything else about the effusion size? Yeah.
So the effusion size here can be quantified around 1.5 centimeter nearly.
Cool. Anything else about the right ventricle free wall?
So I can't commit myself to an obvious indentation or collapse at this stage.
All right.
So I'd like to review. Yeah, there is, but I would like to review it in different images.
All right. Nice. Oh, another great call here. So respiratory variation. It'd be nice if we had a respiratory pattern on there. So you do see, I wonder if we've recorded enough. You get the septal bounce that can occur with tamponade. You don't see it in every single case, but you can get the septal bounce with respiration because of, yeah, I think that's one. I think one looks different from the other because of changing intrapericardial pressures, which with the increased pressure in the pericardial space get transmitted with greater force. So you can get increased respiratory variation with the septal bounce. Great comment.
But
Nice.
this mainly if it's localized effusion rather than if it's circumferential,
I think you
or
can
just because of the RV wall is much thinner than the LV wall.
Yeah, I think you can get it with all of them. I think we're seeing it here with this guy. I think one beat is bigger than the other. I think we put the M mode, we might see that across this one. You know, I think we've got that second cardiac beat is smaller than the first, or that, sorry, that interventricle, left ventricle internal diameter is different between those two beats. So I think you do see it with circumferential as well as localized. You know, it's one of those common features, that septal bounce.
Sam, I lost you.
Oh, I'm just saying the septal bounce can happen with the circumferential pericardial effusions as well as the localized. Is that better? Do you hear all that, Hatton? I think we lost him.
Yes.
All right, let's go to the next decent bit.
Yeah, I can barely hear you. Yep. Yes. Yeah, a little bit, not everything.
Okay, we'll keep going. So on the 2D features, just to summarize, we've talked about the location, the size, circumferential versus localized, free wall collapsibility of the right atrium, right ventricle during systole, diastole, respectively, and IVC. So the IVC is meant to be big and distended. I want to just quickly go to that before I do that one. So what does it mean if the IVC is small and collapsing?
So it still could be a possibility for hypovolemic, low volume tamponade.
Yeah, nice. So we call it pseudo tamponade, right, as well.
Tamponade.
Very nice. And in my experience, patients that I've seen with pseudo tamponade, you can give them some fluid to get you to try and increase up the pressures inside the heart, and that may reduce some of the obstructed blood flow. But the one time that I've done that and then went home, I've then had to come back in the middle of the night to drain the effusion. So now I always drain the effusions when they've got. The last feature I just want to show you with this, which is the dancing heart, swinging heart.
Yes.
And I think you'd normally see that with at least moderate or large pericardial effusions. And again, just an indication of one of that there must be a chronicity to some of the findings. Cool. All right. Doppler features. Give me some Doppler features of tamponade.
So Doppler features, the main one would be marked respiratory variability. So you applied the continuous wave Doppler across the tricuspid and mitral valves, and you identified the differences in the peaks as for the respiratory variability that would happening.
So we could start off by maybe seeing that here. It's again, it's not magic. It's lovely to have the respiratory variation, but we can maybe see one E wave is bigger than another. And what percentage, what variation are you looking for?
10%.
No, again, it's different depending on what guidelines you're looking at, but none of them are 10%, I'm afraid. Some of them say, I think it's 25%. I've got 40 in my mind and 60. Some other, I don't know what everyone else has got.
60 and 30.
60 and 30. I think you 25 and 40. So it's just a variation, but it's more than 10%, I guess, is the go. I don't think you do it as I've just done it there. You know, if you need more cardiac cycles than this to do it. And that's why I hope there's a better one over here. Yeah, here we go. So doing something like this with respiratory flow patterns underneath is really sort of the classic marker. And here we can see that we've got a Vmax of, you know, say 1.1 versus 0.8. So that's what maybe you can call that 30, 35, 25, 30%. Yep. So I think we're seeing significant variation. I can't remember if I did this study. I'm going to say no because I'll bag out the images. You know, I think we want the baseline lower. You want to have, well, you're interested in filling the screen. I think the gain is too high on this, you know, so trying to ignore the fuzz. I'm not sure these measurements are perfect. All right, let's just show the one last view. You wanted the apical 4, sorry, got the wrong one. Can you see that okay, Hatim?
Yeah, it's reflecting well. So yeah, so it looks like it's maybe a touch of an off-axis, but an apical 4-chamber view. I can see definitely a circumferential pericardial effusion, with definitely signs of with signs of RV collapse.
RV or?
So definitely RA is collapsing.
Yeah.
And there's at least, if I slow it down properly, there could be potential RV collapse as well.
Yeah, I thought it was the right atrium, which is the big one there, as you said. And I think I've got. Yeah. What about this? What does this show? So here.
So that's an
down through the right
M mode. So that's an M mode, again, trying to quantify the amount of effusion. There is an effusion over the right atrium, and as well, there is an ongoing collapse of the right atrium, all during the systole.
Very nice. Good man. I think that's great. You know, that's the good standard chat. So you're picking up all the findings. I think you've got them all. My only suggestion, as I've just said before, is in the exam, getting in early, saying that tamponade is a clinical diagnosis, because you know we need to hear that. I think getting the clinical context together fast. You know, if this guy is short of breath and hypotensive, talking about clinical diagnosis, as soon as you start to see that free wall collapse, you've got to suggest that this may be contributing to their features. Could there be other things going on? Of course, something is causing the effusion, and that could be contributing to their hypotension and their breathlessness. Fluid status can be in there as well. That's why I think mentioning the IVC is really important. But I also believe that to try and figure out what is causing the shock, you've got to be thinking about draining this effusion. And so what would be nice to bring into that at the end is talking about management. Because if you've got clinical signs, we've got echo features, you're coming up with differential diagnosis, just give the examiner, talk about the management at the end. And I'd be thinking that we need to drain this effusion to try and figure out if that is causing all the clinical problems, if we can make it all go away with draining the effusion. And in which case, it would be nice to try and say where you would think about draining it. And I guess maybe it's challenging in this guy. So
Yeah.
I don't know, maybe I'll ask other people here. How does everyone drain their effusions? Does everyone use a blind approach, or are people using echo more these days? How does everyone do it? I mean, I don't think there are any hard and fast rules, but I know what I do. How does everyone else drain their effusions?
Well, I use echo, and
Yeah.
I've ended up mostly actually at the apical position.
Yeah, that's exactly the same for me. Yeah.
It's easy access, and often you kind of can follow the needle.
Yeah.
I think I've drained one parasternally where it was a lot bigger parasternally.
Yes, I mean, I'm the same. So I choose the area that's got the biggest pocket of fluid, and it's got the easiest access. So I have to go through the least amount of stuff to get there. And if you can get a nice echo image, you know the lung's not in the way. So I use my echo to show where that is. And I think in this guy, you know, it's not small around the apex. I think the apex might be the go. And I think that's what we used for this guy. But when I'm doing my apical view, I don't just use your standard. I wonder if I can demonstrate it. Where's the RV view? So you don't use your just standard apical view. You're using this off-axis view. And if you can imagine, I don't know if I'll be able to explain this here, but say I got this picture here. I think there's this free space that I might be able to get something into easily. What I'll then do is I'll then tilt my probe around so it's pointing more medially, so that then I'm looking down this sort of off-axis view, so that I've actually got this part that's on the left side of my image in the center. And then that's where I know with my echo probe, if it's pointing in that direction, that's the way I've got to put my needle. So I make, rather than trying to point it, and the risk is that the terrifying part would be to stick it into the LV or to prang the LAD. That's where significant morbidity and mortality is associated with that. You know, if you're going to prang anything, and obviously you don't want to prang anything, but if you're going to hit anything, hitting the RV free wall is by far and away better than hitting the LV. And so that's why you want to be pointing it towards the LV, and pointing it sort of skimming along the LV with your needle means that the area changes from being, you know, 1.4 centimeters to suddenly you've got sort of 5 centimeters to hit.
Oh no, I think you're just saying you want to skim the LV. I think you meant the RV.
No, skim the sorry, forgive me. I absolutely do not want to skim the LV. Sorry, I said that. Yeah, you want to skim the RV. Go down the left side of the image. I'm apologizing. I'm doing multitasking. Yeah, so skim the RV free wall. You don't want to go anywhere near the LV. Nowhere near the LAD. Nowhere near the LV. Stay on the right. Yeah. And then drainage.
Do you like to use bubble sand?
Yeah, I do. And I'll show that to you, I think, on the next case. All right, let me show you the next case. And hopefully I got a nice picture of that. Okay, so this one's interesting. So this guy, was sick as a dog when he came in the second time. So he's come into ICU twice. Okay, so the first time he comes in, so this is when he first came into ICU on his first admission. And he came in because he was short of breath, acute short of breath, comes into ED, he's tachycardic, desaturating, sudden onset of shortness of breath. Emma, do you want to do this one? So sudden onset, shortness of breath, coming into ED. He's a ex-IVDU. We subsequently found him to have MSSA, bacteremia, and infective endocarditis, I should add. He likes heroin, and so he comes in with this acute onset of shortness of breath. You can have that picture first.
Right, so this looks like a modified short axis in the subcostal plane. You can see liver there. And I guess the most striking feature is a severely dilated right ventricle with compression of the shared septum, probably in systole and diastole, suggesting pressure and volume overload. If you want to slow down that cine loop just to confirm that it is in systole and diastole. And there looks like there's severe tricuspid regurgitation associated with that. The thing that I did notice on one of them is that
Oh, do you mind just going a bit closer just so everyone can hear? Why don't you, do you want to stand on this side more? So I'll give you a chair if you like. There.
So on the colour Doppler, there's variance on there, which makes it a little bit tricky, but it's suggestive there is flow convergence, and I'd be concerned that was at least moderate, if not probably severe TR, but confirming in more views and using other parameters.
Yeah, I agree. I don't like variance. I don't know why we use it so much. I guess better.
It's really interesting because his tricuspid valve entry points on this view, it's off axis, but they look quite apical. And his right atrium is massive, and I'd be wondering if he had sort of an epstenoid type valve. It's probably not, but
I think, don't get confused. This is the, maybe it's just some dodgy things. That's the aortic valve we're seeing. That's not the mitral valve. I think you ever look at it, the mitral valve's right there. The tricuspid valve's right next door to it.
Yeah.
So yeah, be careful about that.
But it's interesting that the right atrium is so big, and we don't really understand how quickly that remodeling takes place. So
Yeah, very good, very good. So it looks, I think it's really great comments, and I wonder whether this RV free wall is a little bit thickened. And again, this guy with his drug use. So what do you think of diagnosis, first of all? So acute onset, sudden shortness of breath.
I think he's got something lodged in his pulmonary circulation, whether that's thrombus or large veggie. It's probably more likely to be thrombus. Veggies are usually not that big to cause such severe sort of RV failure and acute cor pulmonale.
Yeah, nice thought. So someone's lodged in this thing. How do you help differentiate? Give me the last thing was, you talked about severity of the tricuspid regurg being possibly severe. What's the, what ways can you tell me about how to estimate the severity of that tricuspid regurg?
Well, you look at 2D, and if there's a clear flail segment or prolapse or failure of captation, you'd be more worried about it being severe. And then using qualitative things like the colour Doppler, the density of the jet. But I think the thing that's really helpful for severe TR is a low velocity V-shaped jet, which suggests rapid equalization between the chambers, between the right ventricle and right atrium, which is difficult to see. I think we're off axis on that.
Yeah, I agree. Anything else? So that was continuous wave Doppler. What can you do with pulse wave Doppler?
Pulse wave Doppler, we can look for hepatic vein flow reversal.
So I think this image would have been helped with being optimized better. I think the gate, first of all, could have been a bit bigger, and it could have been a bit further back into the hepatic vein. And I think the scale could be changed here, but I still think it is semi-useful. It's not the best picture, I do apologize.
And the wall filter perhaps is our best.
Yeah, and the wall filter, nice, the wall filter in there.
There's a suggestion that there is some
maybe there's definitely nothing below the line though, right?
No.
What we can say with a lot of certainty is that there is no obvious systolic forward flow. In which case we've got significantly raised right atrial pressure, and I'm again with you with this wide base jet that we're maybe seeing in there. Just take the variance off again. With that wide base jet, the huge right atrium, we're still seeing significant flow in there. We've seen dense continuous wave Doppler profile. We're not seeing any systolic forward flow. I'd be suggesting we got severe TR here. And so absolutely, this guy was diagnosed then with having a PE. And I'm completely with you that I think there are signs in here also of chronic pulmonary hypertension. I'm wondering that's because this guy is just trashing his pulmonary circulation with some form of injecting something or other. That's interesting. Now, let's pull that back into his second presentation. So he gets over his MSSA bacteremia, he's anticoagulated, we sort him out, and he's discharged, and then he comes back in.
Is Ben or Arnie taking the hot seat now?
Oh, you can hand over to Ben.
I don't mind.
Ben?
Yeah, sure. How long, do you know roughly how long between the two? Like, was this?
Not huge. It's like a month later.
Okay, yeah. Oh, yeah.
So a month later, we've got, he comes again in with shortness of breath. So he's not been compliant with his medications. It's a good story, this actually. So he comes in and he's not been compliant with his medications. He's still back on the, well, he's back on the intravenous drug use, despite chats with him, which went nowhere.
Yeah.
And he's short of breath. And so I think there was the call that, people want to do this, CT scan, they're saying, starting to urgently jump in and saying, we need to consider thrombolysis, I think was the go, because he's, obviously got the same presentation, and everyone's saying that maybe it's the same thing again with possible thrombus that may be infected. Let's thrombolyze him. And I think absolutely right. Someone said, well, let's just do a focused echo. And then we got the formal report comes in, you guys need to do a formal echo. Maybe this guy's got some form of pericardial effusion. So I think it's a really great example here of the utility of echo in the critically ill, and why, basic echo. You just do one view like this, and straight away that should tell you that you don't need to thrombolyze someone, right? And there are other things that might be at play. So again, I think this is really interesting for maybe some of the management side of things. Talk to me through what you see.
So parasternal long axis, the most striking features are pleural and pericardial effusions.
Yeah, awesome. So pleural effusion, that's the important thing not to miss. See the whole thing. We got pleural and pericardial effusion.
So it's writing below the descending aorta versus writing above it. It's my marker. On top of that, I need to slow it down a bit with the left ventricle. So the pericardial effusion appears circumferential.
Yep.
There appears to be RV wall thickening, but I am off axis. But I would be suspicious of some RV free wall bounce. The LV wall looks moving quite freely. I don't think it's bouncing inappropriately. I think it's just floating in the back fluid.
Fantastic.
Giving that motion. The other striking features is, again, off axis, so it's a bit hard to comment, but I'd be concerned about LV hypertrophy or thickening.
Yeah.
And from what I can see of the valves, they look okay. But given his history, you'd want to make sure there's not concurrent IE. Left atrium.
What about the left atrial free wall?
It appears to be moving freely in cycle. So I'd be concerned that it's collapsing.
Yeah. So we talked about this in the last case. It was, we had, as Hatim was saying, RA and RV free wall collapses. Of course, I guess one of the more sensitive features, but what's actually quite a specific feature and is the left atrial collapse. And I think that's what we're starting to see here.
You have an M mode.
I think it's probably better in other views. And
so I think if you slow that down, it appears to have a double flicker there.
Yeah. So I think we're starting to see the left atrium starting to have some free wall collapse.
Yeah.
So it does happen. It's not common, and it can be there. All right. And what's interesting is I think that there, just like you said, I don't think that there is any right ventricle free wall collapse, and that's because why is there no RV free wall collapse?
Well, I don't think it's. I think what we're seeing here is not RV free wall collapse, because I think it's just contracting and we're looking at a different angle, and it looks thickened. So again, I need to see it better to do that.
Yeah. So why is it not collapsing?
Well, it depends on your pressures.
Because it depends on your pressures, right?
Yeah.
Absolutely. So if you're used to having lots of pressures and you've got pulmonary hypertension,
then you're not going to collapse your RV.
You're not going to collapse your RV free wall. So I guess the learning point, which I believe in this case is that you can still have tamponade, but not having your right ventricle free wall collapsing, because I think we're getting. Yeah. Right. So this is why I love talking about this case, because I think we're starting to see other chambers maybe getting collapsed and causing some form of obstruction here.
Yeah.
But maybe this isn't the whole story, right? So talk to me through the money shot. What's it's incredible, right? So why is he short of breath and why is he hypotensive?
So I'm looking at a apical four-chamber view. The most striking feature, or the most striking features are, one, the circumferential pericardial space that has echogenic material in it. It appears to be free floating. I'd be suspicious of either blood or particulate matter in the first instance, given his history of potential anticoagulation. That could be blood. Second most striking feature is the size of his RV and RA. Appears breastly dilated, and the trabeculations are visible.
Yeah, nice. So we've got this heavily trabeculated, thick-walled RV free wall with no signs of any early diastolic collapse. So it kind of goes against tamponade.
Yeah.
I think the right atrium is huge.
Yeah.
And I don't think we've got any signs of RV free wall collapse, but we got this at least moderate, if not large, pericardial effusion here. but I think we've got left atrial free wall collapse that comes in, and that might be tamponade. Is it the whole story? I don't know, but do we think we need to drain it?
Well, yeah, we do. I think we need to drain it because you've got multiple differentials for shortness of breath. And
Fantastic.
this is a driver, a potential one of them. So unless he's in a state where he's well enough to have additional investigations prior to draining this, and it doesn't sound like he is.
No, he's
then
not.
This should be drained first because that will remove it from being an issue.
Fantastic.
Okay.
And I'd guess the other thing that we need to do, you talked about particulate matter. Just tell me
Yeah.
again, do you think this looks like blood? I mean, really?
Nah.
No. What does it look like?
It's infected.
It's infection, right? So we've got to stick a needle in this because we're going to need source control as well. I think so he's got multiple reasons. I think source control, a diagnosis, as well as helping with the differential for symptom control. And this poor bugger, unfortunately, he'd gone from having an MSSA bacteremia the month before, and this group MRSA. So this guy, I mean, I don't know if I told you how old he was, but this guy is 37 years old with an MRSA pericardial effusion, which was probably causing tamponade. It came on quick though. Again, one of the things that surprised me is about, I guess, how big the effusion was and how well he tolerated it. And clearly he'd done that because he's got underlying pulmonary hypertension that had kind of saved him from dropping down dead, I think. And it was only when the left atrium started to go down, I think, and to be honest, he didn't get a lot better when we drained the effusion. I don't know if this is one where I've got the bubbles in it. He didn't get a lot better when we drained the effusion. Look at that. But and it was infection that became a major problem with this chap. Yeah, big dilated IVC. So I think, yeah, that's the learning point with that bit, I think. Just in the last, yes, absolutely. We drained it. Yeah, absolutely. So it passed an MRSA. It would look like, I think we thought it was Kyle first of all. We thought we were praying something, and then like, how the hell can it be Kyle? I think I was being stupid at the time. I was like, well, how have I prayed the thoracic duct going into his heart, and then obviously, just stopping silly Sam. This guy's got pus around his heart. You know.
Apparently, the stuff tastes really bitter. You just taste it, differentiate.
Taste it. Jesus. I think that's probably the most, again, amazing things went on, and he had an incredible transesophageal echo. He was transferred to the cardiothoracic center after 3 weeks because unfortunately from having the pericardial effusion, then the infective endocarditis started to come through, and we'll come on to the next case for that one. He didn't do well, unfortunately, in the end, this poor chap. I think probably the prognosis from having an MRSA in your pericardial effusion is terrible. But he then seemed to have almost grown abscesses in the we did a transesophageal echo looking for infective endocarditis, and it started to look like there were these actual pockets, echogenic free spaces in the free wall, particularly the RV. It was really weird, and I only guessed that it formed some form of myocardial abscess, but the pictures weren't amazing. And we ended up sending him to a cardiothoracic center because we were thinking about pericardectomies and stuff, but he didn't do well. Anyway, this guy did a bit better, sort of. Kylie, do you want to have a quick go at the beginning for this guy?
Yep, that's fine. I'm game if you're game.
Sweet. So let's start off with, so this guy is 61 years old. And he's got a history of, he's got known metastatic cancer, unfortunately, this guy. And he again got short of breath, got a CT. CT suggested no pericardial effusion, but no pulmonary embolism, but a small pericardial effusion. And he had an echo to try and investigate this small pericardial effusion.
Okay, so this is a subcostal view of the heart showing a circumferential echo-free space around the heart. We could lose the depth now that we've had a look at that. Just eyeballing the movement of the right atrium and the right ventricle, it does look a little bit like there's two men jumping on a trampoline. The right atrium's going down and the right ventricle's going down. So depending on the blood pressure, of course, and I always look at the IVC next, he could be ready for tamponade. The other things to say.
The clinical findings, and we got down and we were doing this echo. He was grey, he was muffled, he was short of breath. He said, whatever you do, don't lie me down flat in about four breaths. He couldn't say full sentences.
Well, I guess my next question would be, do you have a statement of choices, sir? What would you like us to do?
Very good.
Yes. I mean, yeah, as well as what looks like is probably going to be a pericardial tamponade with a fairly sizable effusion, is that there's an unusual echoic thickening round near about the lateral annulus of the tricuspid valve. Just wondering whether that's possibly an infiltration from his cancer.
Yeah, interesting.
I don't know. I haven't seen one.
The metastatic thyroid cancer, I don't think commonly does that. The ones that I have seen are things like lymphoma, are the common ones that do that space. But I agree, it's worth talking about that maybe there is something that looks abnormal down there.
Okay. Oh, yeah. So this one we put an M mode through the right ventricle to see if we can see if the right ventricular wall is collapsing during diastole. Diastole will be when the mitral valve is open. So
and also
moved it for me.
From the end of the QRS to the beginning of the, sorry.
Oh, yes, I know. I can't even find my ECG dots, Sam, and I did go looking for them. Yeah. Okay. So diastole is from the end of the start of the T wave, is it?
Yeah, end of the T wave to the start of the QRS. Yeah.
Okay. So the right ventricle, yeah, does appear to be collapsed in diastole. Yeah, and that's when the mitral valves are open too. So, yeah, I think the little man is jumping on the trampoline. Yes, I think he. Now, me as an emergency physician, I don't do a lot of these, so I wouldn't necessarily be putting a needle in until he actually loses his blood pressure and his power of speech. Yes, I'd certainly be putting Dopplers through his mitral inflow and his tricuspid, but you already said he's grey and sweaty. I guess the thing that I would like to know is, can I buy him time by giving him any fluid? So the next thing I would like to look at is his IVC, really.
I'm sorry, I don't think I've got it, which is rather naughty of me. But you can see, I can probably see from the number of echo images, I'm trying to do everything exactly as you said. I've tried to get my flows across the tricuspid valve.
Oh, yeah. Now,
maybe this is naughty of me because I probably could have just from the first image just said, actually, we just got to drain this.
Yeah.
But I've stayed there for we'll have a look through the things. I've probably stayed there for another 10 minutes taking pictures because I knew it'd be a good teaching thing, which is, as every good critical care ultrasound person should do.
Oh, yeah. Now, this is really interesting, Sam, because it enters into the question that I was wanting to ask you from the last tamponade talk last year. And this was, you were discussing briefly the positions that you'll insert your needle. Yes. And you're looking at either the subcostal view, which can need a very long needle and go through the liver. You can look at an off-axis apical view, which I know is your favorite at the moment. And then at the last talk, someone asked about the parasternal view going down towards the right heart. And your answer was that the surgeon you spoke to said, no, don't do that. And I wanted to know why. I mean, you'd already said that putting a needle through the right ventricle isn't quite as critical as putting it through the left ventricle. And if you're going parasternal, that's the sort of the shortest distance from skin to pericardial effusion. I know you've got an internal mammary artery somewhere around there. But do you know why he doesn't want you to go through there?
I think it is not conventional. And his argument was that then you're extremely perpendicular to the heart, and I guess you've got a shorter space to go. I think it's also something that he's not used to doing. He was an old school cardiothoracic surgeon we've got here. Also doesn't like the apical approach because of the risk of damaging the LAD and the LV. But also said that he's used to doing it blindly, and I think in the in his hands, and a cardiothoracic surgeon. He's an extremely proficient surgeon, and he's got me out of trouble when I couldn't drain one by going blindly subcostally. So he's amazing at that. I guess my only counter is that from a, just kind of as a general clinician, my thoughts are I got to go with what I'm comfortable with, and that's using ultrasound to get me to that largest space with the least chance of causing damage. And I think the apical approach can definitely get you into trouble. So you've got to be proficient with ultrasound and really know what you're doing before you just go hammer and tong at the apical approach. And that is something to do in a sort of team-based approach with experts when you're first doing it.
Oh, I wish, Sam, that would be heaven.
Yeah.
Right?
But I think using ultrasound to help guide you is really important.
Yes, we did have a morbidly obese lady with a hemorrhagic tamponade three or so weeks after mitral valve surgery. And we tried all three approaches, got into the pericardial sac every time except for the subcostal. But the only one where we could actually get fluid back out was the parasternal view. And we used the linear probe and were able to actually watch the needle go right down. So.
Beautiful.
But it was the only one that was close enough. And
I think that's a great example of doing what you can. You're trying the conventional stuff, and if that's not working, you've got to try other things. And if you've got ultrasound, you've got the lady's fluid out. You help save their life.
No, we didn't save a life, I'm afraid, but at least we got into the pericardial sac. Yeah, we got in the right place. Yeah. Anyway, sorry, I got off track, Sam.
No,
I really wanted to ask that question.
That was great. Well, I might move now is just in the last couple of minutes, maybe Arnie wants to have a crack at this because we're getting into a little bit more esoteric stuff. So when we drained this guy's effusion, it came back obviously with neoplastic cells in because of his metastatic cancer, which is probably what was underlying the effusion in the tamponade. And the shortness of breath sort of resolved, but not to a great extent. And he ended up showing that he had a strep pneumo pneumonia. He had a pretty good one. So he was in ICU for a few days. He ended up being ventilated and then sent to the ward. Ongoing shortness of breath despite resolution of his pneumonia. Okay, so he's stuck in hospital, and then we get this echo for ongoing shortness of breath. And just in the meaning of time, we're going to
So this is still the same patient, yeah?
Yeah, same patient, but this is now like 2 weeks after he's been in ICU after the effusion was drained, diagnosis of a strep pneumonia. He's got treated, the pneumonia's starting to clear up, and he's starting to get worsening shortness of breath. And there are a few cracking little features in this.
All right, so there's an apical four-chamber view. So of course, in parallel, I'm sort of thinking a little bit about what could be causing that.
I'm really sorry. I've also forgotten to tell you one key important bit of information. So I said that the pericardial effusion grew neoplastic cells. It also grew strep pneumo. So we had strep pneumo in his chest, and he also had strep pneumo in his pericardial fluid. Appropriate antibiotics, everything got better, as I said, extubated, sent to the ward, and now there's ongoing shortness of breath. Sorry, I forgot to tell you that.
So the LV, there seems to be some abnormal septal motion.
Nice. And is that septal motion abnormal every cardiac cycle, or is it respiration?
It seems to vary.
Nice.
Of course, sort of in parallel, I'm thinking whether you could have some features of constrictive pericarditis or
very
something
nice indeed,
developing from that, just from the history.
Really nice. And then with that septal bounce and that respiratory variation, that's exactly right. So my question is, what views do you want next? And this is exactly how it would be in the exam if we were being really, really mean. This is exactly what we'd say. So my question is, what views do you want next? What next?
So I would probably be happy to measure the atria from that view. They're probably enlarged, and then I probably would go to my tissue Dopplers on that view.
And what are you looking for on your tissue Doppler?
So I would look for annulus reversus
And what the hell is that?
with as shown on the left here, a medial E wave that's larger than the lateral. So that's about 10.
So again, one of my one of my pet peeves is people measuring tissue Doppler when it's I can't with the gain too high, you can measure things badly. Again, it's the same with the modal velocity with pulsed wave Doppler, same thing with tissue Doppler. You know, you're looking for where the darkest black bit is. You're not measuring it right at the top, you're measuring it back in there. So that's about 10 on the medial. And then the lateral annulus, I'm measuring it down here at about 7.
So that would be a quite specific sign, and the idea, I think, is that through the pericardium and the inflammation, there's sort of some tethering on the lateral annulus, and then you have some compensatory movement on the medial side.
All right, and the last question for the day in the last minute is, I've done hepatic vein flows with pulsed wave Doppler. What am I looking for? And I'm particularly asking Emma because she's doing her ASE exams, and I guarantee they will ask you this. They love asking this. So we've got constrictive pericarditis that can occur after you've got infection in the pericardial space. It can occur after you've had radiation to somewhere near the chest. It can occur after you've had cardiac surgery. It can occur after pericarditis. Okay, pericardial or infection causes tethering, just like you've heard of that. So free walls of the heart, which means that you get the medial annulus moves more than the lateral, and you get impaired filling of the heart, basically. Okay, so the diagnostic, the pathognomonic echo feature is annulus reversus, where the medial tissue Doppler E prime is greater than the lateral. And then the last pathognomonic thing is what?
You get respirophasic hepatic systolic flow, so it's exaggerated in expiration and the reduction.
Almost. So it will be exaggerated in many things, including tamponade, including constriction, including restrictive disease. So what is, I guess I hate to say pathognomonic, but what is characteristic of constrictive endocarditis, constrictive pericarditis on hepatic vein flows? Anyone? So I remember the acronym is RICE. I hate acronyms, but I don't know why this one's stuck in my head. So it's about diastolic flow reversal. So you get diastolic flow reversal, and it's during inspiration with restrictive disease, and it's during expiration with constrictive disease. And I believe that is what we're seeing here. Okay. I have not given you the flow patterns, which is slightly irritating. Oh, here we go. I did do it. So during expiration, I think we're seeing diastolic flow reversal during expiration, which is associated with constrictive pericarditis. Okay. So they love asking that in the ASE exam, as I said. So just remember RICE, and that's about diastolic flow reversal. So you have systolic flow reversal for tricuspid regurgitation, and then restrictive, it's diastolic flow reversal during inspiration, and then constrictive diastolic flow reversal during expiration. People like J.O. can explain the physiology behind that. I'm really sorry, I just remember the features, and that's the best I can do. All right. Any questions, anyone? Those are the, so I guess, 3 cases on tamponade and pericardial effusions. I guess that first one is that bog standard one. Just, I think everyone's nailing that. Just make sure you talk about 2D features, septal wall bounce, size of the effusion, location, and association with clinical features. Okay, and that's how you get the diagnosis. Doppler, respiratory variation, about 25% across the mitral valve, 40 to 60% across the tricuspid. And those have sensitivity and specificity pointing towards tamponade. Don't forget the IVC. If it's small and collapsing, pseudo tamponade, you can give fluid to buy you some time. I suggest if it's during daylight hours, drain it then. otherwise you'll be back in the middle of the night. And use echo to help guide your drainage of it. And then the nuances would be, if you've got infection or inflammation, think about constrictive effusive pericarditis down the track. And the final thing would be to think about pulmonary hypertension and chronic RV, pressure overload, and the RV, and that changes which free walls get collapsed. And that's the hour. Thanks very much, guys. I'm not here next week. Benny Samadi will be talking about prosthetic valves in my absence. So thanks to Benny, and I'll see you the week after. Okay. Thanks very much, all.
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.